sagittal plane planning plays an important role in the function and longevity of the joint. Too small a component would lead to notching and catastrophic periprosthetic fractures. Too large a component can overstuff the compartments, leading to pain and loss of function. The topics to be discussed are reference axis, describe various alignments, how we do it, and 3D effects of flexion and extension. The reference axis important for sagittal plane planning are femur mechanical axis, distal femur anatomic axis, posterior condylar offset, tibia mechanical axis, tibia knee joint line, and the tibial slope. Femur mechanical axis is defined first by the hip center, which is the center of the femoral head. Femur knee center and the line joining the two is the femur mechanical axis. For distal femur anatomic axis, femur knee center, femur intramedullary center, and the line joining the two represents the distal intramedullary axis. The distal femur flexion angle is formed by the intersection of the femur mechanical axis and the femur anatomic axis. It varies between 0 to 6 degrees depending on the femur bow. Different instrument systems of total knee replacement use different femoral axes for calculations. In the conventional system, the jig cuts the distal femur perpendicular to the intramedullary rod. Hence, the component is placed from 0 to 6 degrees of flexion to the mechanical axis depending on the individual anatomy. Most post-operative X-rays are short films, and the component alignment is based on either distal femur anatomic axis or the anterior cortical plane. Here also, it is important to keep in mind that when component is aligned to the distal femur anatomic axis, it is in 0 to 6 degrees of flexion to the mechanical axis depending on the femur bow. Digital tools in total knee replacement usually follow only the mechanical axis. Thus, technology like computer navigation or imageless robotics will place the component in greater extension compared to conventional. Also, if the surgeon is blinded to the intramedullary axis, the surgeon places the component in an approximate guesswork flexion or extension, even with technologies like robotics. Moving to the next variable used for sagittal planning, posterior condylar offset ratio. Three lines are defined by first the anterior cortex of the shaft of distal femur, posterior cortex of the shaft of distal femur, and a line parallel through the posterior edge of the condyle. The ratio of distance between the two posterior lines to the distance between two cortical lines is called posterior condylar offset ratio. The normal value is 0.44. In tibia, the mechanical axis is defined as the line joining the tibia knee center with the ankle center. The tibial anatomic or intramedullary axis is collinear to the mechanical axis and hence most of the times are used interchangeably. Tibia knee joint line is formed by joining the anterior edge of the medial tibial plateau with the posterior edge of the medial tibial plateau. The tibial slope is the angle between the mechanical or the anatomic axis and the tibia knee joint line. The posterior proximal tibial angle on an average is 81 degrees. Hence, the key takeaways are distal femoral flexion angle varies between 0 to 6 degrees, the posterior condylar offset ratio is 0.44, and the tibial slope is 81 degrees. For post-operative X-rays with the component, to study femoral component flexion, any of the two axes are used. The first is the distal anterior cortical line, and the second is the distal anatomic femoral axis. Both are parallel lines. For studying the component position, from the distal flat surface of the component opposed to the bone, a perpendicular is drawn. Another option can be to draw a line through the pegs. Thus, the component flexion can be noted. It is important to note that this study of the femoral component flexion is with reference to the distal anatomic axis, which is 0 to 6 degrees to the mechanical. Calculation of the femoral component posterior condylar offset ratio is much the same. 3 parallel lines, anterior cortex, posterior cortex, and a parallel through the posterior edge of the condyle of the implant. The average ratio is higher as cartilage thickness is added to the component. Hence, here the component ratio is close to half. The femoral anterior condylar offset ratio is calculated by the line from the anterior cortex of the shaft and a parallel line through the anterior edge of the implant. It is usually around 10 millimeters, but with modern implants, this profile is getting thinner. Increase in the anterior condylar offset stuffs the patellofemoral joint and reduces flexion. A 4 mm increase in offset will reduce flexion by more than 4 degrees. The tibia component slope is defined as the angle between the perpendicular to the tibial anatomic axis with the parallel through the base plate of the tibial implant. It's usually a trade-off between the native slope and the perpendicular. It varies from one implant design to the other. Some have an inbuilt slope in the plastic insert to decrease the necessary slope on the tibial component. Let's dive deeper into the desired values of sagittal alignment variables. Femoral component flexion, posterior condylar offset, tibia slope, and depth of proximal tibial cut. In a CT-based study of more than 1,000 patients, the distal femur flexion angle in 80% of the knees was within 3 plus minus 2 degrees. 11.4% of the Asian population had an angle of more than 5 degrees. Thus, if one is using a technology assisted TKR, one should aim for at least 2 to 3 degrees of flexion. Femur component flexion increases rollback and reduces quadriceps force and patellofemoral contact stress. It also decreases fear of notching and subsequent catastrophic periprosthetic fracture risk. In a navigated study on gap balance and sagittal anatomy, average flexion of 3 degrees was necessary to balance gaps. This would lead to zero extension from the anterior cortical line in most cases. It was found to increase posterior condylar offset by 1.6 millimeters and decrease the anterior condylar offset by 1.3 millimeters. In another 10-year case-controlled study of 297 knees, extension of more than 0.5 degrees predicted anterior knee pain in 87% patients. The reference in study was the anatomic axis of the distal femur. Also, anterior component offset ratio of more than 15% and a valgus tibia were strongly associated with anterior knee pain. Femoral component flexion has a beneficial effect on decreasing overhang of the component. By flexing the femoral component by 3 degrees, the medial lateral overhang in zones 1 and 4 is reduced by approximately 3 millimeters. By flexing to 6 degrees, overhang is reduced in all 4 zones. Once again, for this work, the reference axis was the anatomic axis of the distal femur. Thus, it was an even further flexion from the mechanical axis. A lot of work has been done on the impact of femoral component flexion on the flexion gap. Every 2 degrees of flexion decreases AP distance by 1 millimeter, thereby reducing the flexion gap. The moot question is, how much flexion is desirable? The answer is most likely not dependent on the instrumentation, but on the femoral bow anticipated component size based on both AP and ML dimensions of the bone and the flexion gap. Most per-operative technological aids, including robotics, do not give any information to the surgeon about the femoral bow as well as the mediolateral overhangs in all 4 zones. Thus, even ultra-precise cutting tools might not be able to give us the desired result. We have seen that the flexion of the femoral component is beneficial for rollback, quadriceps force, patellar contact stresses. It decreases the anterior femoral offset, increases posterior offset, decreases flexion gap, and decreases mediolateral sizing. But how much flexion is too much flexion? Increasing flexion beyond 3.5 degrees from the mechanical axis increases the risk of a fixed flexion deformity more than 5 degrees by 2.9 times. Flexion of 7 degrees from the anatomical axis would increase the chances of a fixed flexion deformity more than 10 degrees at the end of 2 years. Another large series of more than 3,000 knees with an average follow-up of 15 years predicted a lower survival if the femoral component was flexed more than 3 degrees from the anatomic axis. Thus, the key takeaways is that though the extension of the femoral component is bad and a strong predictor of anterior knee pain, too much flexion is also not desirable. When performing a technology-aided knee replacement, aim for 3 to 5 degrees of flexion to the mechanical axis after looking at the anterior cortical plane of the femur and the femoral bow. When performing a total knee replacement with conventional instruments, aim for the least possible flexion to prevent a fixed flexion deformity. For the next variable of posterior femoral offset, Bellemann's group found that posterior condylar offset correlated well with the eventual range of motion. A decrease by 2 millimeters of posterior condylar offset led to a decrease in flexion by 12.2 degrees. Another study stating that a decrease of 3 millimeters of posterior condylar offset led to a decrease in flexion by 10 degrees. They hypothesized that the decrease in posterior condylar offset led to impingement by the tibial tray striking the posterior cortex of the femur. Posterior referencing systems cut a fixed amount of bone from the posterior aspect and are touted to be better at restoring the posterior condylar offset. This paper refutes that, saying that there is no difference in offset with either anterior or posterior referencing systems. The desired tibial component slope is between 0 to 7 degrees. A decrease in the tibial slope decreases flexion space and thereby decreases range of motion. A decrease of 5 degree slope decreases flexion by 5 degrees. There is instability with reverse slopes, and also higher tibial slopes have higher failures. On the kinematic front, with increase in tibial slope, quadriceps forces are reduced by 14% and patella stresses are reduced by 11%. Biomechanically, cutting the tibia in the anatomic slope leads to a greater 40% load-bearing capacity, and it increases stiffness by 70%. Thus, we have very narrow ranges to play with. Flexion between 0 to 3 degrees from the anatomic axis, restoring both offsets, anterior and posterior, and getting the correct tibial slopes. Fully understanding the native anatomy is the only solution, and then tweaking it to within 2 to 3 mm or within 2 to 3 degrees. But we know that preoperative planning on X-rays has a limit. It would be only possible when 3D evaluation of the entire lower limb will be made on a routine basis. "3D planning aids in achieving this precision very easily. A brief preview of how it's done. As we can see, here is a component in 5 degrees of extension, leading to notching, patellofemoral joint stuffing, and posterior joint overstuffing. When we reduce the extension and convert it to flexion of 3 degrees, we can see that the notch disappears. It's well aligned, no notching, but there is patellofemoral overstuffing. So if we were to reduce the size of the component by 2 sizes, then we have a component which is a little too small. We have a small notch. There's no patello joint overstuffing, but we can actually see the medial mid-flexion instability. Too much of the posterior cortex is going. So when we get the correct size, there is no mid-flexion instability, no notching, no overstuffing, and the curves of the implant match the native anatomy. Thank you.